in Oxford in England, and I've been asked to provide you with a talk on paediatric respiratory conditions and evaluation. I can sort if you This thing is supposed to be quite interactive, so I'm going to pose questions, and it would be great if some people could like respond back to me. Ideally verbally, but you can put it in the chat, and hopefully I'll be able to see it come through. But this is going to work much more interestingly if people just respond. And I don't care if you're right or you're wrong. I just want people to say stuff to me because it'll make it more interesting. So when I was writing this presentation, I was thinking about what it was that it's useful to know. And I thought, well, it's important to understand the key presenting symptoms and how to evaluate them. And also what often comes through the door in our hospitals to ED. So your sort of classic pediatric presentations, how you might initially manage and investigate them, and red flags for when you need to be extra concerned, and also some of the causes of like common what we would say clinic presentations. So they're not really unwell. They've not pitched up to the hospital very unwell, but they've got a long-term like recurrent symptom, and so they're going to the doctor's office to see and talk about that. So the caveat to this is obviously I'm NHS based, a hospital paediatrician in the UK. So in some healthcare sectors, like a paediatrician would work in the community and it'd be more like what we would call a GP. So they'll see everything from the common cold through, and then if anyone was sick, they'd just refer to hospital. But I'm based in the hospital, so I generally see children that are at least a little bit unwell. So first question, why are babies and children not like adults when it comes to respiratory? There's a couple of hints on the slide. Can anyone tell me why it might not, why they might be a bit different? You're gonna have to,
Yeah,
what's
maybe because they have smaller airway diameters.
Absolutely. So they've got smaller airways diameters. So that means that they've got less reserve. So this picture of this slightly blue baby there was hinting at exactly what you're saying. So they cyanose easily. They become hypoxic more easily. Something that we could cope with secretion wise, like chestiness wise, that we would manage. They just can't manage in the same way. So that's why, one of the leading causes of death in children are respiratory infections, and pneumonias. So that's good. That's one good one. What's another one? What's this child doing? Anyone? Literally, what's she
She
doing?
she's crying while
Yeah.
she may be holding her breath
Yeah, she may be, but she's crying. So why is that a problem? You've gone to. She's not very well. You've been asked to go and evaluate her, and she's crying.
because this is a problem for children because they can't tell us what's the problem. If
Exactly.
they,
They can't.
yeah,
Perfect. So they can't tell us what's the problem. And have you ever tried to listen to the chest of a child that's crying or a baby that's crying? Like, can you hear much at all?
no, we try just to catch some sounds important for us between the crying episodes.
Yeah, we try our best, but it's really difficult. So exactly. So why are they different? So they've got less reserve, which you've said, and they've got smaller airways. They've got that means that they have a unique set of pathologies and conditions, as well as some of the ones that happen in adults, and they can be really difficult to assess. They can't talk to you and they don't always comply with exams. Whereas in adults, generally speaking, they can tell you what's wrong and you can have a good listen to the chest and say, oh, there's crackles or oh, there's wheeze or whatever. But if you've got a screaming baby, you're not going to hear that. So it makes them more difficult. So I put together, I think this will get like shared and stuff. So I just thought I'd put together some of the like common-ish respiratory conditions that I think are important in pediatrics. Obviously, there's like rare stuff that's even rarer than this, but these are the common things that I come across in my work in the hospital. And generally speaking, they can be split into your acute. Can you see my? Yeah, you can see my. Um,
Of course, yeah, we can see
yeah,
that.
yeah. So you've got your acute presentations there. They pitch up to like ED, so emergency department, A&E, or a doctor immediately. And then you've got your ones where there's sort of long-term underlying issues with symptoms, non-resolving problems, that kind of thing, that maybe present to clinic. And it's worth knowing. I'm not going to go through what all of these things are, but we'll talk about when to consider some of these more like long-term underlying condition type picture. And then obviously there's neonatal specific respiratory problems, which I'm not going to go into because it's just too much. But there's certain things that you really just see in the newborn, but I'm not going to cover them. So presenting complaint, and we're talking about assessment. And when we're thinking about assessment, the reasons we're asking questions, the reason why we're examining, we're always asking ourselves two questions. What is it, and what am I going to do about it? So there's three main presentations when it comes to respiratory, isn't it? Which you could all tell me, but it's cough, it's noisy breathing, and then it's what we'd say is difficulty in breathing. And for each of these things, you're gonna ask about more about those complaints. And it's always about teasing out the detail. So what does the thing sound like? What does the noisy breathing sound like? What does the cough sound like? What was its onset? Did it come on suddenly? Has it been there all the time? Has it been there since birth? Is it getting better? Is it getting worse? And is there anything that you think has either triggered this episode or tends to trigger um, the child to suddenly have coughing or suddenly have noisy breathing? So, in a bit more detail. So, if you think about cough, so we've got character. So, we've got wet cough, a dry cough, barking cough, and a paroxysmal cough. So, let's have a look. Yeah. So, does anyone know what a barking cough is characteristic of? Hopefully, this will work.
Because it is maybe for the someone writes group, yeah, group.
Yeah. Should we have a listen? See if this works. I bet it's not going to work now. Right, yeah. Can you hear that? Can you hear that seal-like barking cough? Not really. Oh dear. No, we didn't.
No.
Okay, that's a shame. Why is that then? Okay. I mean, I can impersonate it if we need to. See, I'll
See,
try.
I'll try.
Doctor, I think that you can share the sound as you share the screen through the Zoom settings.
Okay, so
Okay, so
it's not going to work, but um, this will be shared, and I'm sure, and you can just click on the links to have a listen. But basically, a barking cough sounds like this, and it sounds like a seal. Um, And if you hear that, you know exactly what the problem is. The problem is croup, which is inflammation of the upper airways of the voice box. And it's something that adults don't really get at all. They'll get like a hoarse voice, a bit of laryngitis, but the kids they get this like characteristic barking cough, which is croup. Um, there's also this is whooping cough. So this is a paroxysmal cough. So again, you probably won't be able to hear it, but if you can see what the child's doing. No, okay, fine. So with whooping cough, what you hear is this like, and they cough, and they cough, and they cough, and they cough, and they cough until they don't have any more breath, and they still can't breathe, and they still can't breathe. And then there's this big hoop at the end, which is which is what gives it the name whooping cough. And then there's bronchiolitis, which tends to happen in kids less than 1 year old, and that's quite a lot of wet, wheezy sounding cough. This would be much better if my links worked, but anyway. Um, and then you're asking about timing. Is it persistent? Is it there all the time? Is it not? And then anything that triggers it as well. So like someone with wheeze or asthma, often like there'll be a trigger to it. So maybe they've got a cough or they've got a cold anyway, and then it's gone to the chest and it's a virally induced wheeze. But it's worth knowing that young children will have 6 to 12 respiratory infections a year. So that's massive. So that's one every 2 months. So parents will often say, "My kid's always coughing," but the key thing the key thing to the history is, are they're coughing, but then do they have these periods of time when they're not coughing? Because that's reassuring. If you've got a child who's coughing and they're coughing for 6, 8 weeks, and at no point do they stop coughing, that's a red flag, and that's concerning that there might be something more going on than just a simple lower respiratory viral tract infection that's taken a while to resolve. We'll come back to this. We need to. So none of this is going to work very well because my links don't work. You can't hear them. Um, but what is stridor? Tell me, is stridor which one? So we've got stridor and we've got wheeze. Which of them is inspiratory and which of them is expiratory?
Stryja is expiratory, I think.
Anybody like to put to suggest something else?
Yeah, Stryja is
I
inspiration.
think they could be both.
Yeah, it's inspiratory. So it's this
Yeah.
noise. It's this noise, isn't it? Okay. And then we've got wheeze, which you may be able to hear from the end of the bed, but generally speaking, you're going to need to use a stethoscope, aren't you? Um, and that's an expiratory noise, which is more like a and does anyone know what the difference is in terms of like stridor, where the problem is in stridor, that inspiratory noise? Whereabouts
Up,
is the problem?
upper respiratory tract.
Upper respiratory tract, exactly. And where's in wheeze, where is the problem?
Maybe like the larynx.
Below the larynx, so in the lower respiratory tract, yeah.
Yeah.
And grunting, what's grunting? Why do kids grunt?
The baby is trying to maintain the end expiratory pressure.
Exactly. So they're trying to maintain their ending respiratory pressure. So classically, they sound a bit like they're crying, but they're not. So they're like, and it can be quite a like a soft sound, so softer than that. And grunting in a child is always a bad sign. Stridor we can manage, depending on what it is. Wheeze we can manage. Grunting, you've got a very, very, very sick child, so it's always a concern. Um, Laryngomalacia, I've put it in because laryngomalacia is a floppy larynx. And so if you've got a child that's got an acute stridor, so suddenly come on, it's likely to be related to either they've swallowed something and it's got stuck in the upper airway, or they've got a croup, so they've got a viral tract infection that's affecting the larynx, and so they've got croup. But in some babies, they're sort of just born with what we describe as a floppy larynx, and that's what laryngomalacia is. And so these children sound a bit like they've got noisy breathing and a bit like a bit stridulous, but that kind of noisy inspiratory breathing from birth. But they're otherwise generally okay. And in that situation, the diagnosis is usually laryngomalacia, and it's something that they will outgrow um, as time gets on. But it can, if it's severe, it can affect feeding, and sometimes they need support with their feeding through high energy milks or NG feeding, even nasogastric tube feeding, to get them through that period of until they're a bit older and their larynx is less floppy and it no longer causes problems with their breathing. But always be aware that if you've got a child that's got stridor and it's sudden onset, and it's not associated with cold with like a cold, or they seem very well and they were literally fine 1 minute, mum's left them in the room, come back, and the next minute they got stridor, always consider whether they've inhaled an object. So it could be foreign body. So I'll just leave this in here because we'll share the slides. But it essentially covers sort of the main causes of stridor that we've talked about. So we've talked about laryngomalacia in newborns, and then in kids we've got the croup um, and other infectious concerns. Does anyone know what the difference is between what you might see in croup and what you might see in something like epiglottitis?
I know that epiglottitis, the patient will be very ill and sick, while the croup may be a reasonable one.
Yeah, no, exactly. You're absolutely right. And what happens to the stridor? Is it a loud stridor or is it often quite a soft stridor?
I think soft for epiglottitis.
Yeah, it is. It is soft. And what's their cough like? Is it harsh or with like a barking noise like croup, or is it softer and muffled?
I like muffled sound.
Yeah, often. So if you've got a kid with stridor, but they look toxic, they look unwell, they're very febrile, and they've got actually quite a soft stridor and a soft cough. So it's kind of look, you think it's croup, but actually they look more unwell than that. Their cough isn't barking, it's soft. And often they'll be drooling as well. Then that's epiglottitis. Um, or highly likely to be epiglottitis, and that's a bacterial infection and needs immediate antibiotics. Um, we've talked about think reasons to think it's something like a foreign body. Um, so we've got there's obviously difficulty in breathing. Sometimes kids won't really have a cough. Sometimes they won't have noisy breathing. They'll just have fast breathing, and that's what the parents will bring them in for. So it's always, as you will know, it's always being aware that respiratory rate changes with age. So there's different values for, a kid that's 6 months old compared with a child that's 6 years old. And so you need to know what those values are. And the other thing to be aware of is fever will drive a high respiratory rate. So if you've got a child who's febrile, got temperature of 38, 39, they may well often have a high respiratory rate. And as soon as you give them some paracetamol and their fever settles, then their respiratory rate settles, and that's very reassuring. Parents often describe the kids' breathing as sucking in. So if you're speaking to a parent on the phone, you can't see the child, they're telling you what their child looks like. They'll often say things like sucking in because they're sucking, oh, that's what they say in the UK anyway, because the kids are sort of sucking, the skin's being sucked in under the ribs and around the ribs because they've got that much effort. So there should be some links that will go on that you should be able to see the videos even if you can't hear them. Um, Oh, the other thing they might come in with is apnea, and they may just say that my child's had a floppy episode. So any of those things might be how a child with difficulty in breathing presents. And floppy episodes and apnea are much more likely in young babies. Never trust a baby who is maybe slightly premature, 36 weeks, for example, is only 3 weeks old, so hasn't quite got to what would be their due date and has got a bit of a cold. Because for those children, they may not have much difficulty in breathing. The first thing they might do is just have simple apneas, and that might be the first sign that they're unwell. Um, okay, so what else would you like to know? So we've done history of the actual symptom. What other things would you like to know? I'll have a look at the chat as well and say what people are saying on the chat.
Like investigation or physical exam?
Like no, like assessment. So we've done it's a pediatric history. So I've taken I know that they've got a cough or a difficulty in breathing, but what else do I need to know? It's pediatric history. So what else do you cover in a pediatric history? So like past medical history would be one thing. What else would you ask in histories?
Is the cough being suddenly or gradual?
Yeah,
The
so you can
onset of that.
Yeah, so you can ask more about the presenting complaint, but what are the like different headings that we use when we're talking
The
about
the
this?
oral intake.
Yeah, yeah, yeah. So that's really important to know.
Yeah, his weight. There is any weight loss, wasting. I want to ask if there is an exposure to second contacts
Yeah,
nearby. And someone in the chat, you can see the chat, has typed
vaccinations. Yeah,
vaccination, if he is up
yeah,
to date or not.
yeah. Very, very relevant. Very relevant. Um, so this is what you need to ask. Okay. So associated symptoms. So you've got some of them. So you definitely want to know if there's been a fever or not. You definitely want to know what the feeding is because as much as like what is it, you're asking yourself, what am I going to do about it? Because if there's a because one of the especially if you're looking at a baby, if they can't breathe, they will not feed. And it may be that they have a simple chest infection, bronchiolitis, which we'll talk about. Um, and actually, there's nothing much you're going to do about them apart from support them with their feeding so that they don't become dehydrated. So feeding's really important. If a baby is taking less than two-thirds to half its feeds, that's a bad sign. That's a red flag. So that would mean admission to hospital and support with feeding. Passing urine because that I'm asking that because I want to know that this child's well hydrated or not. If they're passing urine, I'm somewhat least happy that they're managing to get enough fluid into them to not be shocked, to not be septic, and to be well hydrated. And if they're not passing urine, that for me is a particularly concerning feature. And then you want a general systems review, like because very occasionally you can be out of breath but it's not respiratory driven. So if you think about a child in DKA, diabetic ketoacidosis, they will have an altered respiratory pattern, but the issue is not with their lungs. The issue is that they're very acidotic and they've got a high respiratory rate because they're blowing off their CO2 to correct their acidosis. It could be that they have a history of cardiac problems. That's relevant. It may not be that they have a respiratory problem at all. It may be that they're in heart failure. And so they've got wet lungs. And that's what's causing them to have to be chesty. And then you're going to ask just the general things to PEDS history. So always past medical history, so associated illnesses, and if you've got a child who's got other underlying health problems, that maybe puts them at more risk of a serious of a serious illness or serious outcome. So this relates to what am I going to do about it? I might be more likely to admit them to hospital. I might be more likely to give them antibiotics. Birth history is very, very relevant. Why is birth history relevant in something like in a like a 4 week old?
Maybe the baby is premature and need oxygen supplementation in ICU, in NICU, I mean.
Yeah, absolutely. So if I've got a baby who's quite small and was premature, I'm extra worried about them. So they may have really very minimal symptoms of any sort of whatever the illness is. They might be very minimal, but if they're ex-prem, they're much more likely to get sick. For example, in bronchiolitis, they're much more likely to get sick. So I'm much more likely to admit them for observation and not discharge them because I'm worried about them. So family history is relevant always, immunisations, which someone said, medications, growth and development. So someone mentioned growth. So this is especially relevant if you've got someone come to clinic who's got kind of a long-term problem. So they've had a cough for a while. They've maybe got recurrent chest infections, which they get over, but they seem to have about, 6 courses of antibiotics a year. Um, so if they're not growing well, that is concerning. That's a red flag. And that means that you can't just say this is a simple cough. It means you need to go on to investigate further. And then social history, someone mentioned. So contact with pollution, smoking makes some respiratory conditions worse. So, for example, in a kid with bronchiolitis, which we'll talk about, if the parents smoke, we know that those children are much more likely to get bronchiolitis again. And if the parents stop smoking, that potentially will make a massive difference to whether their child ends up being admitted to hospital in the future with it or not. And then contacts and stuff, like where do they live? Is there TB? Like if this is a child with a chronic cough, is there TB around? Um, Is anybody else unwell with similar symptoms? And then physical assessment. So what sequence do we always follow? You're in ED, you're in A&E or an emergency situation. You've got a child that comes in, they're not very well. What sequence of examination do you follow? It's to do with the alphabet.
ABC or
Yeah,
ABCD approach.
yeah, A, B, C, D, yeah, always. And that's how we treat as well. So, airway's pretty easy. Is it patent or is it snotty? And then with regards to breathing, we're looking. And it's like we say, like traditionally, look, feel, listen, but good luck feeling a child's chest and feeling anything with it because they won't stay still and they're probably crying. But anyway, have a go if you want, and then listen. So this, I hope, will work. And I don't, even if you can't hear it, I think we can still talk about what we can see. So this is all about respiratory assessment. Oh, I thought this would work. Mm, what's that up? Mm, okay. Oh dear. Right. There'll be a link to this in this. This is, if you've not seen it, this is one of the best resources you will ever have for assessing children. It goes through in detail different how to assess a child and examples of all the different symptoms and signs that they can have. So if we go to basic child assessment with videos.
When a child has respiratory difficulty, they can recruit other muscles to help inflate the chest.
Can someone tell me what signs they're seeing in that child's chest when you're watching? Someone describe their work of breathing to me.
These are called accessory muscles in this context.
You may be able to hear you may be able to hear the voiceover. That's irrelevant. I just want you to look at how the child's breathing.
Forced diaphragm movement causes abdominal breathing, and pulling on the sternomastoid muscles in the neck causes something called head bobbing in.
So what do you notice? What are you noticing?
Subcostal retraction. Subcostal retraction.
Yes, subcostal recessions. Exactly. So we're looking. So when we're talking about doing a breathing assessment, we're asking, is there subcostal recessions? What's the effort of breathing? Um,
Abdominal breathing. That must be involved.
so you can see that this child's really sucking in, and unlike adults who have a very stiff chest, and they can be quite unwell, and you won't see such increased work of breathing. In kids, you can see it much more easily. And then if we go to here.
Grunting, which we mentioned earlier, strictly speaking an accessory muscle in babies, as the body tries to open up all of the possible airway space.
What's happening here with this baby's nose?
Nasal flaring.
Nasal flaring, yeah. So when you're talking about respiratory effort in your examination, you need to say whether any of these signs are there or not there. So is there grunting, which we've talked about already? Is there nasal flaring? Is there head bobbing? Are there subcostal intercostal recessions? is there a tracheal tug? Is there use of accessory muscles? But you also need to say, are they lethargic or are they sleepy? Because in a child who's got a respiratory problem, that is not okay. If you see a child and they're chugging away, but they look sleepy, they look lethargic, that child is quite possibly going to need intubation and ventilation. So always be aware that lethargic and sleepy children who have an underlying respiratory problem that have come in acutely unwell and are getting tired need to be escalated to a senior straight away. Um, And then the rest of A, B, C, D, E, as it relates to the uh, to respiratory issue, is so circulation. Are they dehydrated? If you've got, like we said, if you've got a kid who's septic from a lower respiratory tract infection or has bronchiolitis and is doing very poor with their feeding because they can't breathe very well, then you want to know, are they dehydrated? Are they not dehydrated? Like, do I need to give them extra fluid? Do I not need to get them extra fluid? You want to be having a look at, especially in babies, like, is there any evidence of heart failure? So very occasionally what happens is a 6-week-old, 4-week-old, 6-week-old will come in and everyone think, oh, it's just a viral lower respiratory tract infection because they get them tenner-penny, they get them all the time. Like, it's a very common presentation in that age group. But every so often there'll be a child where they haven't got a viral infection, they've got heart failure, especially if mum's not had any good antenatal care and lots of scans within the antenatal period. It's possible that that child could have an underlying heart defect that's not previously been identified, and they may just present in heart failure, so a rapid respiratory rate. And it can be very difficult to differentiate whether you think the child's out of breath because they're in heart failure or out of breath because they've got a lower respiratory tract infection. But what couple of signs might make you think it's heart failure on examination?
Maybe according it's a right or left heart failure.
Yeah, yeah. So what might
Like
happen?
edema, elevating the jugular vein and like that. Maybe crackles in the lung.
Absolutely, yeah. So the amount of crackles in the lung, you can get that in both a lower respiratory tract infection or heart failure. But yes, crackles in the lung, but exactly what you said. So signs of fluid overload. So key thing is like their tummy. Do they have a big liver or not? Is there any evidence of a big liver? They may or may not be edematous. But if you've got a child who, especially a baby or older, who has got crackles bilaterally and they've got a big liver, just stop and think, is this heart failure? Could this be heart failure? Do I need to get an x-ray to have a look at the size of the heart because that's quick and easy? Do I need to get an ECG? Do I need to request an echo if I can? And then with disability, as we just said, if you've got a child who's tired, who's confused, and they've come in with a cough, with problems with their breathing, and they're lethargic, that is incredibly concerning and immediately needs to be escalated to your senior, because that could be a sign of impending sort of complete respiratory collapse and failure. And then also, have they got a fever? Because that might point you in the direction of what you think's going on with them. So these are some case histories. Um, so essentially, I just want you may or may not know the diagnosis, but have a go, and then we can talk about what that diagnosis means. So we've got a 1-month-old boy. He's come to the emergency department in the middle of winter in the UK, and he's got a 2-day history of nasal congestion, dry cough, and a fever. And over the past 12 hours, he's working harder with his breathing. And he's not feeding very well, and he's had fewer wet nappies. He's otherwise well, but he was born at 35 weeks gestation, and his parents smoke at home. On arrival, he seems angry and upset and irritable, and he's tachypnea with a fast respiratory rate. He's working hard with his breathing, and he's got scattered wheeze and crackles, and his oxygen saturations are on the low side, so 92% in room air. So does anyone know what this is? This is like literally probably the most common like diagnosis in children coming into hospital, at least in the UK, in babies.
Acute bronchiolitis.
Yeah, it's acute bronchiolitis. Okay. So yeah, what other diagnoses do we need to bear in mind? Just always at the back of our mind, just in case. So one I've just literally just talked to you about. So what happens if this child had a big liver? What might you think?
Heart failure.
Yeah, so just always have in the back of your mind, could it be anything else with heart failure? And then other simple common differentials are, is this a bacterial pneumonia? So this is classic of a bronchiolitis and not a pneumonia, but we just need to bear that in mind. What aspects of this history are particularly concerning in how severe this illness may become?
Maybe reduced feeding.
Yeah, yeah. So things so bronchiolitis, what is it? We'll come back, maybe we'll come back to the uh questions. But basically, as you will probably already know, it's essentially a viral chest infection. It's caused by common cold viruses, classically respiratory syncytial virus, RSV, that people outside the medical profession have literally never heard of, but we pediatricians are, it's probably the most common virus that brings kids into hospital with bronchiolitis. But flu, adenovirus, rhinovirus, any common cold virus can cause it. And basically, it's what gives everybody else the common cold and a snotty nose. But in children, it goes and it sits on their chests and it makes it difficult to breathe. And the reason it's difficult for them to breathe is they get secretions. Now, we have got quite large airways, so we can absolutely cope with those secretions. Maybe we have a bit of a cough, maybe we don't. But in these children, their airways are so small that even just a tiny amount of secretion is enough to block it. And that's why they get bronchiolitis and this wheezy, crackly noise in their chest and difficulty with breathing and difficulty with feeding. And older children and adults don't get it. So classically, it's in the less than 1 year olds. Um, and the general history is that they often start off with a snotty nose and then they develop a cough maybe a couple of days later. And it tends to be worse on day maybe 4, around about day 4, 5. So, what's concerning about this history in terms of time course? Where is this child in terms of their time course? How many days have they been ill for? Someone say it.
Can you repeat the question to answer you accurately, please?
Oh, yeah. How long has the child been ill for? Where does it say in the history how long the child has been ill for?
Uh, two 2 days.
2 days, yeah. So do we expect them to probably get worse, given that we know that bronchiolitis is worse on around about day.
Yeah, day 3 and day 4 is the most worst time.
Exactly. So that's concerning that we've got a child who's already presented, who's already having difficulty with breathing, who already can't feed very well, and they're only on day 2. So that for me is a bad prognostic sign. Okay. Um, Something else that is concerning. So somebody already said it. So he's got reduced feeding and he's fewer wet nappies. That to me says that this child may well need some support with their feeding. Um, and something else is relevant here. How old was he when he was born?
He's a preterm.
He's
Yeah.
preterm and he's young. So he's only a month old and he's preterm. So being young is a concern. Being preterm is a concern. Put those two together. I'm very concerned about this child. So at the moment, they may just need some help with their feeding, but there's a good chance that this child's going to need some support with their breathing. So his oxygen levels is 92. So in the UK, in bronchiolitis, we allow oxygen levels to be 90 to 92 before we give oxygen. It might be different in other countries. But this child's trajectory is not looking good. So that's what we're concerned about. Investigations. Any investigations that people would like to do?
We
Chest
concern
X-ray. Just X-ray CBC.
Yeah, it might do, yeah.
No, it's a clinical diagnosis, but
Yeah,
we concerning about reduced feeding. We just
yeah.
observe the patient and giving fluid and observation just.
Yeah, that's it. So in the UK, and it will be different in different healthcare settings, and it's very much dependent on what people do within their hospital. But generally speaking, as like we would say, it is a clinical diagnosis. So we don't do any investigations. We don't do a chest X-ray because we it's not gonna change our management, and we just support with feeding and then oxygen if they need it. The only investigation that we do in the UK is we do a nasal pharyngeal aspirate, so an NPA. So basically like a nose swab to see what virus it is. And that is really not about looking after the patient or help treating the patient. It's actually about being able to what we call cohort children together. So in the winter, the ward is overrun. We haven't got any beds, and normally we would keep children with RSV away from other children because we don't want it to spread around the ward and go to other kids that are at the moment don't have bronchiolitis. But what we do is if they've got bronchiolitis, if they've got RSV positive bronchiolitis, and the next two people are RSV as well, we'll put them in the same room together or the same bay or ward area together. So that's why we'll do a nasopharyngeal aspirate. But basically, it's just to group people together so that we can kind of keep infections localized on the ward, but we can still put people close to each other. But otherwise, we don't really do any investigations. Um, so management is literally just support with feeding, so NG feed, and support with oxygen, so low flow oxygen or high flow oxygen if they need it. Um, is there anything you would advise the parents about? What are parents doing, which is making this
Yeah,
much more
I would advise him to stop smoking.
yeah,
Smoking cessation is very important.
yeah, absolutely. So stop smoking. Um, talked about that. So in the UK, we now have a couple of options for trying to prevent bronchiolitis. So we have a maternal immunisation programme that came out, I think, last year. So we basically immunise mums in the third trimester against respiratory syncytial virus. And the hope is that by immunising them then, they pass on their antibodies in utero to the babies. The babies are born and then they have milder disease. We still don't know whether this is translating to less bronchiolitis in our hospitals in the UK, but it's something that we'll be watching over the next a year or so. And we also have something called nirsevimab, which is basically a monoclonal antibody that it's an antibody against respiratory syncytial virus, and it's an injection. And we give it to babies who are, for example, preterm to protect them. So they get this injection of nirsevimab before they get exposed to bronchiolitis. So at some point, just before winter starts, which is when our bronchiolitis season is. And then that the idea is that antibody that they've been given against RSV protects them against severe RSV infection and bronchiolitis.
Doctor, can I
Yeah,
ask you a question, please? Are
yeah.
there any alternatives for this nervizumab?
Are there what?
Alternatives to the
Yeah,
nervizumab?
there will be. So we used to use something called palivizumab, which will have a brand name. Um, and the names of the drugs sometimes are different in different countries. They have different brand names.
Yeah, great. Thank you.
Yeah.
I,
But the palivizumab used to be given every month. It's once a month for 6 months. Whereas nirsevimab is only once, so it's a one-off injection. So
are
it,
there difference in the efficacy?
yeah, that's why we've moved towards it in the UK.
Are there
Um,
differences in the efficacy between them?
say again?
Efficacy difference between them.
Yeah, yeah. I think they're supposed to be, they're two different, palivizumab and nirsevimab are supposed to be about, I think they're about equivalent in their effectiveness, but it's just much cheaper to give nirsevimab because you only have to do it once, whereas palivizumab, you have to keep bringing them back, and that costs money for the different visits. And also, no one wants their kid to be having 6 injections. Like, it's not nice.
Thank you, Dr. Roy.
Yeah. So the next one is we've got a 2-year-old girl who's come to the urgent care centre by with her parents because she's got a barking cough at night. She's had a bit of a fever and a runny nose. And at bedtime, this barking cough's got a lot worse. She's got quite noisy breathing, especially on inspiration. She's drinking a little bit less, but she's otherwise well and she's immunised. On examination, she's alert, but she's miserable. She's got a bit of a fever, a hoarse voice, and she's got respiratory stridor at rest. Her oxygen saturations are okay. What do you think the diagnosis is in this child?
Croup.
Croup, absolutely. And so she probably sounds like, and then she'll have a stridor as well, like, okay. What other diagnoses do we need to bear in mind? We've talked a bit about it. I mean, it very, very much sounds like croup, and it probably is. She's got a fever, she's 2, she's got a barking cough, it's worse at night. But what other diagnoses do you just need to bear in mind?
Epiglottitis.
Yeah, epiglottitis. So if she looked more toxic, if she was particularly unwell. Bacterial tracheitis is similar to epiglottitis in that they look toxic and unwell. And then she's 2. I mean, it was the middle of the day, she was fine, and then suddenly she had this stridor and then
Foreign body aspiration.
yeah, foreign body. So yeah, they just always have those things in the back of your mind, just in case the history doesn't quite fit. But this is typical of croup. What investigations would you like to do, if any?
Nothing. It's a clinical diagnosis.
Yeah, absolutely. In fact, don't do anything. Because what must we never do in croup? They've got a compromised airway. What's the last thing we want them to do? What do kids do all the time when they see a doctor? What do they start to do? They start to get upset and cry. So they cry, and that crying increases the inflammation of the larynx. So if they cry, all that's going to do is that's going to make their inflammation even worse. So you go from a child who's maintaining their airway, who, yeah, it's narrowed, but they're managing, they've got a cough, but they can breathe, to a child that can no longer breathe. So like you said, it is a clinical diagnosis, but also you don't want to do anything to them, basically. Management plan. Does anyone know what the management plan is for croup?
We give
According to severity.
Yep, you can look at severity, yeah. What's the first line treatment, really?
dexamethasone.
Yes, so steroids, so dexamethasone. Occasionally people have used pred in the past, but yes, absolutely, dexamethasone. Right, so you've given her some dexamethasone, but she's still got quite a bit of stridor, and she's working hard, and you're concerned about her. What else could you give her to tide her over?
Epinephrine nebulizer. Epinephrine nebulizer.
Yeah, absolutely. Epinephrine, so adrenaline nebulizers. So the dexamethasone will take an hour or a couple of hours to work, whereas the adrenaline is immediate. But the effect of the adrenaline doesn't last very long. But it might tide you over until the dexamethasone really got into their system and really got to work on reducing that inflammation and making it easier for them to breathe. So yeah, someone said this about how you can rank it from sort of mild, moderate to severe. But anyway, you can see first line is always dexamethasone, and if they have a good response to dexamethasone, there's no there's no stridor, there's really no cough, then they'll just go home. But if you give them that and they're worse, then like as we said, you'll give them adrenaline. And then they'll have a good response to that, and hopefully they will just get better. They might need a few doses of adrenaline until they really settle down, or they might have a poor response to it. In which case, there's not a lot you can do apart from call your anaesthetist, because if they lose their airway, that's it. So I have had children that I've had to intubate, well, not personally, but where I've had intubated and ventilated just because they just don't get better and they're losing their airway. But yeah, it's basically dexamethasone, oxygen if they need it, and nebulized adrenaline. If they've got severe work of breathing and they're not getting better, think about speaking to your anaesthetist, who might need to intubate and ventilate them if they lose their airway. And do not upset the child. So always talk about using the bubbles, like you're blowing bubbles and stuff to keep them happy. whilst they're getting their medicines, etc., to try and stop them crying and losing their airway. And this is pretty much the last case history, I think. I'm nearly finished. So we've got a 3-year-old boy who's come to ED and he's got 2-day history of runny nose and cough and a bit of a fever. He's quite out of breath, and that's been getting worse. He's had a few episodes of this last year, especially when he's had cold, but he's not been diagnosed with asthma. He's eating and drinking a little bit less. On examination, he's tachypneic and he's got a prolonged respiratory phase and a wheeze and some subcostal recession. His saturations are just about okay, 94%. What do you think the diagnosis is?
Asthma, maybe.
Yeah, asthma or what's the other one?
Hyperreactive airways.
So virally induced wheeze, so one or the other. At this age, often in the UK, because he's getting wheezy and because that wheeze tends to be triggered by cold, we'll call it virally induced wheeze until they get a little bit older. But if he was 3 and he was getting this wheeze and it was not associated with a cold, maybe it's middle of summer, maybe he gets hay fever, maybe he's got eczema, maybe parents have got asthma, then we might say this sounds more like an asthma phenotype. It makes very little difference what we do in the short term in terms of this particular episode. He's clearly wheezy. Again, investigations, nothing really. Sometimes if they're older, people do peak flows, but in the UK, I never see that being done. So how do we deal with? So he's got wheeze, viral-induced wheeze or asthma, or an exacerbation of asthma, either or. What are we going to do first? What's first line treatment for it?
SABA nebulizers.
Yes, so salbutamol, so short-acting beta agonists, absolutely. So in the UK, what we do is we give 10 puffs of inhaler, or we'll give a nebulizer. And what we say basically, if they're in oxygen, we give a nebulizer. If they're not in oxygen, we'll give it through the inhaler. Yeah. So often what we'll do is we'll give 10 puffs or we'll give a nebulizer. And if they're particularly tight, what we'll do is we'll give 3 of them back to back within an hour, which we call burst therapy. And then we'll review. So either after those three lots of salbutamol nebulizers within an hour, they're either a lot better or they're not, in which case we might give them a repeat set of burst therapy. I'll put them on hourly salbutamol. And then and we may or may not give them steroids. The jury is still out here as to whether we should give a steroids or not. In asthma, we definitely give prednisolone. In viral-induced wheeze, it's still not, people still haven't quite decided, so you can do either really. Okay, so let's go through what happens with this child. So we come in with asthma. He's not needing salbutamol at the beginning. Sorry, he's not needing oxygen. So he has some salbutamol, and then we do this burst therapy. So 3 lots of salbutamol in an hour, and then we assess his response, and then he'll either be improving. But if he's not improving, then we need to think about adding in some other treatment. So if you've got a child who's had a set of back-to-backs, a set of burst therapy, maybe a second set of burst therapy, they're still looking unwell, or they're stuck on one hourly salbutamol administrations and not managing to go more than 1 hour before they become completely wheezy again, then you're going to add in ipratropium, and then you're going to put an IV line in. And there's 3 drugs that we give in severe wheeze, and that's IV magnesium, possibly IV steroids, IV salbutamol, and IV aminophylline. So often people will give here IV magnesium first, and some children just respond so nicely to it. So they're really working hard. They're needing lots and lots of salbutamol. They're jittery with the salbutamol. They feel awful. You give them a bolus of IV magnesium, suddenly they're better. Some children won't respond to that. They'll need some aminophylline. And again, that's aminophylline is a bit like, it's related to caffeine actually, the actual underlying medicine. And so for some children, a bolus of that and an infusion of that is what works. If you've managed to do those 2 things, and they're still not any better, there's a good chance this child is going to tire. What would be red flags in a kid with an exacerbation of asthma? So you're looking after them. Why would you start getting worried and thinking, oh, I need to call my senior?
Normal CO2 in the ABGs.
Absolutely, yeah. So
And
severe,
silent chest.
absolutely, yeah, yeah. So I've not written that there, but yeah. So poor work. So tiring, poor air entry, silent chest, or you're giving a lot of treatment and there's not really any change, and there's either a normal CO2 or rising CO2 on the gas. That is usually a sign that we're heading for intubation. So this was going to be whooping cough, but I won't do it because A, we're running out of time, and B, the links aren't working, so you can't hear this child. Can't hear this child. And then there's just a couple of other things that sometimes comes up when I'm speaking to like medical students. So if you've got a child who's got cough and a bit of a fever, sometimes it can be hard to know if it's viral or bacterial. So in the UK, what we tend to say is if they've got a cough and a fever, and you can hear like focal crepitations, then we'll give antibiotics. If you can't, then we'll assume it's viral and we won't. If they've got a bit of a chest infection and they're wheezy, again, we'll assume it's viral and we won't give antibiotics, generally speaking, unless they're looking particularly unwell. And the antibiotic we give is generally amoxicillin because most bugs that cause lower respiratory tract infections are streptococcus, which are highly sensitive to penicillins. Um, Sometimes you have these kids that sound a bit like they've got bronchiolitis, but they're older than one. So they might be two or even three, or even older children. And so they've got lots of creps everywhere. And that is like a bronchiolitis, but in an older child, and we call it a viral pneumonitis. And they can be quite sick with that. And they basically end up on oxygen for ages, like a week or so. Um, and then the other thing to think about is if you've got a kid who has been unwell with a chest infection, and maybe they've been on antibiotics for a week or so, but they're not getting better, their fever is persisting, their cough is persisting, they've got increased respiratory rate, always think, do they have an effusion? So if I've got a kid who's been treated for a chest infection, but they've been unwell for a week, I'll always get a chest X-ray just to clarify whether I might be dealing with an effusion or not. Um, yeah, and then you see these two X-rays. It's just comparing an effusion with atelectasis. So which one's the effusion? Is it this one or is it this one? Which one's the collapse? Which one's the effusion?
Yeah, the collapse is on the left of the screen,
This one?
and the right is effusion.
Sorry, the right. Yeah, I'm looking at it. Sorry. Yeah, yeah. What? How? Yeah, you're right. So why? Why is that the collapse?
Yeah, the collapse leads to a pull effect on the lung. So the heart is pulled to the side that is affected.
Absolutely. Yeah. So it's
So
important.
we can't see exactly on the right. It's more on the right regarding the right picture. It's pushed on the right.
Yes, exactly. Yeah.
Slightly, yeah.
Yeah, yeah. So you've got midline shift, haven't you, towards the hepatity in this one. And that obviously indicates loss of volume, so that's collapse. And you can see why actually. This child's got an endotracheal tubing which has gone down the right main bronchus. So that's why they've got a collapse. Whereas this child has got everything's been pushed to that side because there's fluid, there's stuff taking up the chest cavity there, which is fluid, and it's pushed it across. So that's your effusion.
I think there is a chest tube.
Yes, there is.
Am I right?
This thing, then I don't. I think that's the child's oxygen
Yeah,
tubing
maybe.
because the chest tube's usually fifth intercostal space,
Yeah.
mid axillary line. But
Yeah.
yeah, they're not very well. They're on oxygen.
It looks like it's a coiled and go back to the center if you
yeah,
go with it.
maybe I can from what I can see, it's like this. It goes like this round, and then I sort of see it going up there. But anyway,
Okay, thank
yeah,
you.
there's some sort of tube, isn't there? Right. And then just things to think about. So if you've got a kid who's got recurrent lower respiratory tract infections, so they've often got antibiotics, they're often coming into hospital, or they've ever been admitted to PICU. Yes, they might have they might just be unlucky and they're having recurrent episodes of acute, LRTI, bronchiolitis, wheeze, etc. But always consider other options. Um, I won't go through them, but I've put on here some of the other things that we sometimes see coming through and like what the classical or key bits of the history are that often indicate that diagnosis. And it's been recorded, so you can just read it at your will, just because it's about just over an hour now. Um, but yeah, always think if you've got a child who's got recurrent LRTIs who is not growing, um, there's something going on underneath this all that needs further investigation. So that might be TB, cystic fibrosis, immunodeficiency, interstitial lung disease. Or if you've got any kid who's got an underlying neuromuscular problem or cerebral palsy, for example, a significant cerebral palsy, they often get recurrent LRTIs because they don't have a safe swallow and they can't cough properly. And so they just get worse and they just get LRTI after LRTI after LRTI. Right, that is essentially it. These are amazing resources. Please go on Spotting the Sick Child. It is unbelievably great. It will take you through the assessment of a child. It will show you all the signs and symptoms that you get in children across all the different A, B, C, D, E systems, and it's absolutely fantastic. And then obviously there's a link to our NICE guidelines and our British Thoracic Society guidelines, which tells us how to like manage asthma in the community and how to manage croup, etc. So that is the end of this talk. I'm sorry that none of the links worked. That really has made the whole thing a lot less good than it would have been. But anyway,